Everyone. Thank you all for joining us today. My name is Edmary Guzman Velez. I'm an assistant professor at Harvard Medical, and I've been working, I work with Jaquel at the Multicultural Alzheimer's Prevention Program. Today, we have the privilege of learning more about Dr. Ethan Cicero's research. Dr. Cicero is a tenure-track assistant professor at the Nell Hodgson Woodruff School of Nursing at Emory University. He's also a Robert Wood Johnson Foundation Future of Nursing Scholar and a Butler Williams Scholar. Dr. Cicero's research is focused on evaluating the interrelationship between social inequities and the effects of adverse and affirming social conditions on the health and well-being of transgender, non-binary, and other gender-expansive adults. Particularly, he's interested in promoting healthy aging and reducing the risk for Alzheimer's and other related dementias. Their scholarly work has contextualized the healthcare experiences of transgender adults, holistically examined their health, and filled methodological gaps in transgender health research. Dr. Cicero is among the first researchers to delineate health differences and document health disparities among transgender subgroups, and is a widely recognized expert in transgender adult health. Their work, which has been supported by NIA, the Robert Wood Johnson Foundation, and Alzheimer's Association, has led to national and international attention with media outlets like CBS News, Huffington Post, and others. Dr. Cicero's research has also been used as scientific evidence in multiple U.S. Supreme cases, which is very cool. It's also shaped the position statements of several professional nursing organizations and was actually featured by the NIA Sexual and Gender Minority Research Office. Dr. Cicero received his Bachelor of Science in Nursing from the University of North Carolina at Chapel Hill, his doctorate in philosophy from the Duke University School of Nursing, and he also completed a 2-year postdoctoral fellowship in the biobehavioral research training and symposium science program at the University of California in San Francisco School of Medicine. So we are so excited to have you here and to learn more about your research. Just as a reminder, please, if you have any questions, add them to the Q&A. And we'll go over them at the end of the presentation. So the floor is all yours.
Thank you so much for the warm welcome. I'm really excited to be here. Let me get my slides up so we can begin. Let's do this. And okay. Moving things over so I can see.
Yeah,
all right, good. Welcome. Thank you again. My name is Ethan Cicero. I use he or they pronouns, and I do really want to give a warm welcome to everyone that's joining us, and also a very appreciative thank you to Harvard Medical School and Mass General Hospital and the MGH MAPP team for inviting me and providing this opportunity, and also valuing and centering the brain health of gender minority adults. So wanted to really kind of jump in and start off with letting you know what we're going to do today, because I believe most of the people on this call know a lot about Alzheimer's disease and related dementias and cognitive impairment among the general population, but the nuances around gender minority adults and what that means may not be as well understood. And that's really what I want to focus on today by describing health and social implications of gender minority population, and why it's really important to think about the entire population, not as one as one group, but really think about the different subgroups among the population. And we're going to look at what type of risk factors that we know about for Alzheimer's disease and related dementia impact gender minority adults, and then also want to go over some best practices for identifying data from research participants to identify as gender minority adults. Small disclosure, besides being excited and anxious about presenting today, my speaker notes, which help me focus my attention on particular topics, I can't access them. So I don't want to ramble because I could talk about this for days and hours, but I really wanted to give you all the highlights of some information to really give you information to help you with your research and with your clinical practice, and also know how we all can contribute to advancing knowledge in the space. So the disclosure I have is some of my research is supported by the Alzheimer's Association. And let's talk about some terminology so we're all on the same page. I'm going to use gender minority as an umbrella term that describes individuals who self-identify as transgender, non-binary, and those with a gender or gender identity, as well as a gender expression that does not conform to social and cultural expectations associated with the sex assigned to them at birth. This is more of an academic term, and community members may not align with this terminology. And throughout the talk, I may say gender minority or transgender interchangeably. Some of the research that I'm going to go over with you today uses transgender as a term, and they use that as an umbrella term. Others do not. So I just wanted to put that out there in case it's confusing. See, and gender identity is a person's inner sense of being a girl or woman, a boy, man, or a combination of these, or something else, or even having no gender. And then transgender and cisgender, these are both adjectives. So if someone's gender identity is not aligned with the sex assigned at birth, we could classify them as transgender. If it is aligned, I'm going to use the word cisgender to describe these individuals. And then non-binary, this is usually an umbrella term that describes gender identities outside of the male, female gender binary. The important thing is terminology has been evolving over time. A lot of it is community driven, and now we're starting to see more information coming from scholars in academia like gender minority, or you may have heard sexual minority. And that describes people with a sexual orientation that is not heterosexual or straight. However, there is so many terms that community members use to describe their gender, and some individuals use multiple terms to describe their gender. And this can be very confusing. And how do we understand the different groups, and how do we categorize people in research or in clinical practice? And the key is to really kind of understand some of these nuances, because there is variation related to generational and geographic and even cultural variations. Some of what we're seeing is prior to the 2000s, as people started to identify with potentially being transgender, they use words like transsexual or female to male or F to M or male to female M to F. And today, some of that terminology is really considered inappropriate. Whereas now we're seeing more people are using multiple terms to describe their gender, to provide more nuance and communicate really who they are. Again, as terminology is evolving through community members, people are identifying with the more precision that these terms offer. And so an example could be someone may identify as agender, genderqueer, and a non-binary person. Some other terminology that we're seeing more of is transfeminine or transmasculine. And these terms really describe more of a spectrum of individuals that are more on the feminine side or on the masculine side, as well as gender expansive. That term sometimes is considered part of like a non-binary similar. And then two-spirit is for some indigenous communities to describe also a more expansive gender identity. When we think about the gender minority population, it's not a small population, and it's continuing to grow. It is made up of diverse subgroups, so we really need to think about that when we're considering brain health. Unfortunately, the US Census did not collect information about gender minority people, so we don't have a very accurate count. This 1.4 million is based on data that's almost 10 years old right now. However, trans and gender minority people could be of any sexual orientation, including heterosexual. But we also need to think about gender identity as fluid. It could evolve over the lifespan, and it's not a linear process. And what this means is any type of gender identity milestones, like identifying as transgender, feeling as if you do not align with the sex assigned to you at birth, potentially even starting any type of gender-affirming medical interventions. These occur at varying time points across the life course. Again, something really important to consider in the aging gero brain health space, because when we think of human development, we think of children at certain ages, they have these stages that they go through, whereas someone that identifies as transgender may identify at an early age. They may not share that information with other people. They may not do any type of social or medical intervention to align their physical appearance with how they identify. It could happen at any point in the lifespan. And gender-affirming interventions include social, non-medical approaches, such as changing someone's name and pronouns, how they appear, they present their gender, as well as medical approaches, gender-affirming hormone therapy, gender-affirming surgeries. Both are evidence-based and shown to improve health and well-being. But unfortunately, not all individuals that want those medical interventions have access to them. Just a quick note about gender-affirming care, particularly about gender-affirming medical interventions, because of all the socio-political news over the last couple of years. This isn't new, but this is something that is inundating us right now. And there's a lot of misinformation in there. But gender-affirming medical interventions are evidence-based and medically necessary. They significantly improve quality of life, psychological functioning, while decreasing suicidality and body dissatisfaction. The World Professional for Transgender Health has set guidelines and protocols about gender-affirming medical interventions, and the majority of mainstream medical societies, professional societies, also support and approve these approaches. But I want to take a moment about perspective, and I quite often get asked, so you do trans health research. So that means you look at LGBTQ people or lesbian, gay, bisexual, transgender, queer, questioning, and so on individuals. And I push back and say, no, I really focus on gender minority, trans, non-binary, gender expansive people. And it matters because let me show you here. This is a map that highlights protective and harmful laws related to LGBTQ people. And I just pulled this about a week ago from the Movement Advancement Project. And you can see this map, green has more protective laws, red has more harmful laws. This represents LGBTQ people as a whole. Doesn't look great. However, if I just want to look at laws that are related to gender identity, it's a much worse picture. So this perspective matters. And while there's a lot of similarities as far as social and health inequities that are shared across sexual and gender minority people, it is still very different. And even within the gender minority population, there is a lot of variation with social and health inequities among community members or these subgroups within the gender minority population. Let's think a little bit about stigma and how this affects health. But stigma is experienced across the lifespan and in all areas of life. And this could look like prejudice or discrimination to even physical violence and sexual assault and even fatalities. The diagnostic labeling of gender minority people as disorders, that is a form of stigma. And what we're seeing is happening as a result of stigma. There's health insurance coverage and benefits are being denied for medically necessary and preventative health care. There's limited providers available or limited training curricula provided to healthcare professionals. We're seeing a lot more anti-transgender legislation being passed to strip individuals of basic human rights. Also, sometimes stigma may seem really insignificant, like misgendering someone or even intentionally using the wrong gender and the wrong pronouns. But what it leads to for the individual is internalizing this self-hatred because society is telling them that they're not valued as individuals. So gender minority people may anticipate and expect this rejection or discrimination, become hypervigilant, and potentially not even access healthcare because of the discrimination that occurs in healthcare settings. which we're seeing a lot of individuals being denied just basic healthcare, not special healthcare related to gender minority or gender affirming interventions, but just providers saying, we don't take care of people like you. And stigma that is assigned to, gender minority people does give rise to social and health inequities that are experienced across the population. What we're seeing is these psychosocial stressors and social inequities are linked to an increased risk for unhealthy aging. So we're seeing individuals more often living in poverty, to be unhoused, unemployed, higher rates of physical and sexual assaults, and barriers to healthcare, but also this long history of medical and research mistrust due to how gender minority individuals have been treated by medical professionals and researchers. These inequities are also compounded by other forms of oppression, such as racism, ageism, sexism, homophobia, classism, and ableism. So it's really difficult to just really kind of tease out what is going on at one point in time, because an individual shows up being a member of multiple marginalized communities. And across the lifespan, these chronic exposure to oppression and discrimination can cause or exacerbate health problems and chronic health conditions, which we're seeing in the literature now. So we think about the health inequities that are coming from stigma. We're seeing health status really varies among the different gender minority communities, and it's coming from this cumulative effect of the chronic stress on physical and mental health. So we're seeing higher rates of anxiety and depression, HIV, and worse physical health. Gender minority individuals are more likely to be living with a disability and have multiple chronic health conditions, and even an earlier onset of chronic health conditions. So let me turn our attention now to Alzheimer's disease and related dementia in the United States, or ADRD. This is where you all probably know much more than I do. But if we think about how many people are living with ADRD and how that is projected to continue to increase as our population ages, you can expect the same within the gender minority population. We do know that rates of ADRD is higher among Black and Hispanic communities compared to non-Hispanic white communities, which is a point that I'm going to refer back to later when I share some information about relevant studies in the area. And Alzheimer's disease is a degenerative brain disease and the most common form of dementia, which dementia is really a collection of symptoms related to cognitive decline. And this is where I kind of want to focus now, like, well, what do we know about gender minority adults in ADRD? Well, they're underrepresented in the research. And often research studies do not include measures to be able to identify gender minority people, so we're not learning more about the population. So little is understood about the epidemiology and risk of ADRD and cognitive impairment in gender minority people. But we do know that gender minority adults experience a greater number of health and social inequities, and they are also disproportionately impacted by most of the modifiable risk factors that account for approximately 40% of dementias worldwide. It remains unclear as far as how does ADRD prevalence and risk vary among the different subgroups of gender minority people, and what is the impact of using gender-affirming hormone therapy. But what we do know, we can look at some studies. So there's one study by Christina Dragon and team where they looked at the 2015 Medicare claims data for adults that were eligible by age. So we're 2,100 transgender adults. And what they found was that dementia prevalence was much greater, 18% versus 12%, in transgender versus cisgender adults. And then among transgender adults that are 65 and older, they also had higher rates of diabetes, depression, hyperlipidemia, hypertension, and obesity. Again, risk factors for ADRD and cognitive impairment. In a similar study from researchers from the University of Florida, they looked at EHR data and claims data from Floridians, over 1.5 million Floridians, which accounted for almost 1,800 transgender adults. And they also found that overall, the trans adults had higher prevalence rate compared to cisgender, as well as they broke it down by age group, which to me, this is concerning considering 18 to 49-year-olds still significantly higher rate than cisgender individuals. The over 50 years old group, although it wasn't significant because they didn't have enough power, it still is pointing us in the direction that there is higher prevalence rate of ADRD among transgender versus cisgender adults. Among the 50-plus-year-olds, they also saw smoking, depression, diabetes, hypertension, and sleep disorders were higher. Again, modifiable risk factors for ADRD risk. But I know there's been a lot of attention in ADRD research in general and looking at hormone therapy among cisgender individuals. And how does that really translate if we think about long-term use of gender-affirming hormone therapy among transgender individuals? This is an area of research that is up and coming. I guess there's always been research here, but the long-term effects of it, we're really getting more into this. And I know among cisgender individuals, some of the research findings is not aligned with each other. But when we look at this one study from the Netherlands, it has a small sample size of transgender women. But the takeaway point was there was no indications of adverse cognitive effects from long-term gender-affirming hormone therapy. They did do a mini mental status examination, and while some of these differences among trans women, cis women, trans women and cis men were significant, they were very minor. And what researchers are really attributing this to is more of the social conditions that are creating higher rates of diabetes and cardiovascular disease, anxiety and depression, and not necessarily from the hormone use. Well, if we don't have much information about ADRD, we can also consider subjective cognitive decline because this is not a healthy sign of aging. And before a diagnosis of ADRD could occur, the brain is already changing. So if we consider how can we kind of look backwards on this pathway to see, well, what is going on in this preclinical stage? This is where subjective cognitive decline comes up. And it is a self-reported experience of worsening memory or thinking. And it could be one of the first clinical manifestations of ADRD. Several researchers, including myself, have leveraged the CDC's behavioral risk factor surveillance system to really better understand the brain health of gender minority adults and look at subjective cognitive decline and related functional impairments. So I'm going to go over some of these studies with you. First, behavioral risk factor surveillance system, or BRFRS, excuse me. It's an annual cross-sectional telephone survey. It's the oldest continuous one going on in the United States. It's conducted by the CDC and implemented in all US states and territories. It looks at health behaviors for non-institutionalized adults age 18 plus. And there's a core set of questions, some state-added questions, and then optional modules, which is key to my discussion with you today. Some of the chronic health conditions that is asked of participants, they've ever had a diagnosis of one of these items. Again, a lot of these are linked to cognitive impairment and ADRD. However, in 2014 was the first time they offered this optional module where states could not only ask about participants' sexual orientation, but about their gender identity. And that's what I'm going to focus on today. So they asked participants over the phone, do you consider yourself to be transgender? And if they affirm that, then they ask, do you consider yourself to be male to female, female to male, or gender non-binary? The language that is being used hasn't changed in almost 10 years. And quite often, not everyone will say yes, that they identify as transgender to a stranger on the phone. But if someone also identifies as non-binary, they may not say, yes, I'm transgender, and then give you like a subgroup of being non-binary. They may consider themselves separate from being transgender. So it's just some of the nuances related to the gender minority population and how this measure is not ideal, but it's still giving us some information. In 2015, there was a subjective cognitive decline optional module offered, which I'm going to break down for you too. For the SCE measure, they asked participants ages 45 and older. self-reported if they're experiencing confusion or memory loss that's happening more often or is getting worse. If the participant said yes, then they asked follow-up questions regarding limitations with daily household activities, social limitations, if they needed assistance, if they were able to get the assistance that they needed. And they also asked if they'd spoken to their doctor about their memory concerns. So one of the first studies that came out was led by Dr. Flatt. And although we looked at subjective cognitive decline among sexual and gender minority adults using Burfus data from 2015 to 2018, some of our findings we disaggregated based on whether someone was a gender minority individual of any sexual orientation, and that's what I'm going to focus on today. And what we found was among the transgender or the gender minority adults, just over 17% endorsed SCD, and in comparison, cisgender men and cisgender women were closer to 10%. The only other group among the sexual and gender minority individuals that had a higher prevalence rate were bisexual individuals, and it was 17.6%. It's the first kind of indication that something is going on, and it made me really curious to want to be able to take a deeper dive and look at gender minority adults. So I followed that study up with doing just that. And I'm going to highlight two. The first one, I wanted to compare transgender adults versus cisgender adults. And I used the 2015 to 2019 poll data. But then I also wanted to look at within the gender minority group and how we were able to see three different subgroups. I wanted to see what prevalence rates look like, and if there were any differences among these groups. So decent sample sizes break down some of these findings. So when I looked at transgender versus cisgender, first I wanted to report, my sample sizes and what the prevalence rates look like. But once I collapse it down to gender minority versus cisgender, it's still 17% versus 10.5, 11%. So the gender minority adults were 73% more likely to report STD than the cisgender adults. But strikingly, the gender minority adults that did report STD were 3 years younger than the cisgender adults. And this was a significant finding. And among those with STD, they still had effects where their function was affected. And I think this is another important area to really dive further into it and understand the needs and the care needs of the gender minority different populations. But we found that gender minority adults were 2.3 times had greater odds of having an SCD associated functional limitation than cisgender adults. So when I took a deeper dive and let's look at trans women, trans men, and non-binary adults, there was a significant difference among these groups. So I wanted to compare the groups to figure out, well, where is this significance being driven by? So during post-hoc pairwise comparisons, we saw that trans women in relation to trans men and non-binary individuals, both crude and adjusted odds ratio had much greater odds of having STD. And when we did our adjusted models, we adjusted for age and the birth of survey year. When we looked at different types of limitations, I wanted to call out, while all of them are not necessarily significant, but the majority of trans women, trans men, and non-binary people who endorse STD were living with a limitation related to their memory. In the last study that I wanted to highlight, we really wanted to understand what does this look like from an intersectional lens with transgender adults from minoritized ethno-racial groups, knowing that there's a 1.5 to 2 times greater likelihood of cisgender, Black, and Hispanic communities having ADRD. So when we broke this down, we looked at minoritized ethno-racial transgender as well as minoritized ethno-racial cisgender, and then white transgender and white cisgender individuals. And this was, we used 2015 to 2020 poll data. And across the study groups, the minoritized ethno-racial transgender individuals had a much higher prevalence rate than the other three groups. When we then wanted to see, well, which groups, when we did our post-hoc pairwise comparisons, the minoritized ethno-racial transgender groups had much greater odds when we looked at versus white cisgender and also versus minoritized ethno-racial cisgender adults. You know, in our adjusted odds ratio, we did adjust for age, education, and birthday survey year, but 2.5 to almost 2 times greater odds of SED. Again, this is concerning, and really being able to understand what is coming from this, because we do see in other minoritized groups, discrimination is associated with cognitive impairment and changes in the brain. But this has not really been examined among the gender minority population. The other significant finding is even among white transgender and cisgender adults, which is striking to me. And I think this really calls out social position. It's a cross-sectional study, so you can't make those causal inferences, but this is what our literature is showing us now. So in order to really understand and to advance knowledge in this space, we need to be able to have data that we can identify from our gender minority participants. So I wanted to go over some best practices that have been adopted recently by the National Institute of Aging. That is, we're going to start seeing this in the Alzheimer's Disease Research Center program at the National Alzheimer's Coordinating Center, or NAC. And with NAC, they had a uniform data set. They are have been updating this to version 4. And right now there is a preview, which I'm showing the form on the right-hand side of the participant demographics. I don't think this has rolled out completely yet, but it's about to. And what I wanted to focus on is how to use this and how you can use this in your studies now. Wanted to highlight the text before the questions were asked, because I think this is really important. The next 4 questions ask about your gender identity, sex assigned at birth, sexual orientation, and intersex status. This information will be used to help us improve health, well-being, and quality of care. And by gender identity, we mean the inner sense that you have of yourself as being a man, woman, or a different gender. Gender identity can be different from your sex assigned at birth or your sexual orientation, and it can change over time. I was fortunate enough to be part of a team that made these recommendations to the NAC group about how to kind of measure some of these items. I'm going to focus on the gender identity and sex assigned at birth, show you how individuals could respond to these questions and how you can interpret this and identify individuals. We looked at published literature, anything that was cognitively tested, but thinking about who is going to be filling out these forms, it's not just going to be the person living with cognitive impairment or ADRD, it could also be their caregiver too. And individuals can be of varying ages. And this is an area where further development is needed to cognitively test some of these items, given the research and clinical implications. So we really needed to understand not just if someone's transgender or a gender minority person, yes or no, but really look at the group that they're within, so then we can ask more precision questions moving forward once we identify who's in our studies. So let's look at these questions. So we're going to do a 2-step approach where we're going to start off with asking the individual what their current gender identity is, allow them to select all that apply, and then also the sex they were assigned at birth on their original birth certificate. So if we look at someone that said man for gender identity and male for sex assigned at birth, we can consider them a cisgender man. These are concordant responses, and the same for a woman for gender identity and female assigned at birth, cisgender woman. However, if we look at someone that selected transgender woman for male, and I'm indicating 2 separate participant responses with the colors, and then someone that is identified as a transgender man and female assigned at birth, we can refer to them as a transgender man or woman, respectively. Whereas some individuals may not use the word transgender when describing themselves, but we're seeing this discordant responses where as a researcher, we could conceptualize this response as someone as a gender minority individual. They did not self-identify that way. They did not self-identify as transgender. So we can also use a more inclusive terminology as a trans feminine individual, where we're always going to focus on their current gender identity. And I'll show you the same could be in the reverse as a trans masculine individual. But what happens if someone picks female for their sex assigned at birth, and then they choose one of these other options or even write in one of their options? How do we classify that individual? Again, they could be classified as a gender minority individual, even though they did not use those terms. But to be respectful, you could use a gender identity that they selected and indicate that they were assigned female at birth. There's that's the research and literature is really kind of going in that direction because there are nuances related to the sex that were assigned at birth. And not every trans or gender minority individual has used, wants to use, has access to gender affirming hormones. Even though there are kind of protocols in place, it is person-centered. People have different goals when using gender affirming hormone therapy. And we can't just assume that they're using it in a way of going from one type of individual that they were assigned at birth to how they identify their gender today. We can also say, kind of in a similar way, for those individuals that are assigned male at birth and they use different terms or multiple terms to identify their gender identity. So before I open up to questions, I also wanted to, again, thank the MAPP team for inviting me and allowing this discussion, but also to the support and guidance from my mentors and colleagues at Emory and across the country. I continue to learn from all of you, and I hope to be a source of inspiration and look forward to kind of collaborating so we could put our best minds together to really improve the brain health of gender minority adults. It's awesome.
Thank you so much, Dr. Cicero. This is really amazing work. We have one question on the chat. It says, do you know whether there were any differences in the type of cognitive concerns reported by trans versus cisgendered individuals?
We don't. So the Bertha surveys, it was a straight question. It was yes or no, whether or not someone felt like they were having memory issues, but the context of that was not included. And this is somewhere where my research is going to kind of dive into. I think when we think about cognitive impairment and ADHD, a lot of the times the questions that are asked are really focused on the risk factors that we know of white, cisgender, heterosexual men, and not really specific to the psychosocial stressors that are specific to minoritized communities. We're starting to see more work in that space. I can highlight like Lisa Barnes's work, where we really want to understand the lived experiences of Black individuals and Black communities and how their cognitive health is impacted by systematic and structural racism. I really want to go in that same direction and understand how psychosocial stressors that are specific to a trans or gender minority experience affect health and particularly affect brain health, and be able to quantify that and see what areas of the brain are impacted and how they're impacted by some of the stressors that I went through today.
I'm curious about whether it's, if I'm not mistaken, the research that you presented is based on here in the United States. Is there any similar research in other countries that may have different policies and so on?
It's a great question. And unfortunately, there's really not. What's coming out from the Netherlands, they've followed cohorts over time. The social implications of that area is much different than the United States. And they're starting to publish information that we're seeing that gender affirming hormone use is not what's contributing to health inequities. It is the social aspect. But advancements in ADRD on understanding among these communities, that is slow. But I think it's starting to pick up, and I think we're starting to see it. It's also challenging in areas of the world to do this type of research and to have participants, because even though there's a lot of concern and safety issues in the United States, in some areas of the world, it's even worse. And I think that hinders our advancements as well.
Yes, thank you. We have another question. Do you think it's better to ask the sex, gender identity, and sexual orientation in person, or are people going to feel more comfortable filling it out on a form without a human interaction?
That's a great question. And I know a lot of the research that has looked at these types of questions, they found that people that do not identify as a sexual or gender minority individual understand and are comfortable answering these questions. I think often the gender minority person may not know exactly what the other individual is asking, because there's been so much confusion between sex and gender, and also wanting to protect themselves from potentially being discriminated upon. But the only way to find out is to ask these questions. And when we looked at non-response values for some of these items, people were still answering the question. I think it's important if you're going to incorporate these questions into your own surveys, is to really think about the other items on your survey. So as if you're just asking in a demographic state, but then you're asking more about health questions, and you're saying, well, these are questions for women to answer, and maybe it's about reproductive health history. Well, it's important to know that transmasculine individuals also should be asked those questions, given we want to know about anatomy, we want to know about behavior, and not everything is specific to a woman or specific to a man. So I think not only how you ask the question, but the rest of your survey, as well as any type of visual cues. If someone's in person, are you indicating this is an affirming space? And that you recognize the diversity among gender and sexual orientation. And I think that also helps individuals feel comfortable knowing that this information is going to help you take care of them or help you improve their health.
Wonderful. Dr. Jorge Sina says, thank you for this wonderful presentation. Do you have any recommendations for resources, organizations that we might offer our gender diverse patients with subjective cognitive concerns? And it can be psychoeducational, treatment related, etc.
Yeah, thank you for the feedback. With subjective cognitive, concerns, there could be other factors really contributing to it, and it may not be necessarily dementia. It could be sleep, it could be other medications, it could be nutritional, it could just be stress. So this is just kind of an indication, and I think encouraging your participants or your patients to continue to discuss their concerns with their providers, so then their provider can step in and say, I'm also concerned because we've ruled out these other conditions that could be contributing to your memory concerns, and potentially needing to see a neuropsychologist for further evaluation. But this area there isn't like a central location for resources. I know the CDC has published some information about subjective cognitive decline among the LGBTQ community. The Alzheimer's Association is also doing this as well. And more is coming out. I think as I and other researchers are learning more about this and really focusing on these communities, we're putting that information out, and the communities want this. So if I can continue to look, and I can follow up with the host today, and we can disseminate some more information. Yes, my mind is drawing a blank. I'm sorry. I apologize. I probably need to make sure that I'm sleeping enough.
That's wonderful. Yes, please feel free to share any resources. Jorge works with us in the Multicultural Assessment and Research Center, so it'd be nice to have these types of resources for our patients. Please feel free to continue to add questions to the Q&A. I have a question too. So there's some research in development stage that shows that, kids who've been through trauma and a lot of discrimination you do find differences in brain development and also, even markers of inflammation and so on. And so I'm curious if there's any research related to that in adolescents and kids who are gender diverse. And if you already see some of these cognitive differences, that early on, that yeah, that may be in a factor that it just continues to propagate even into late adulthood.
Yeah, that's a great question. And while my research and my interest hasn't been with younger individuals, I really focus more middle-aged and older. I agree. Like adverse childhood experiences is creating this kind of health trajectory. And with the Burfus data, they did have an optional module about ACEs. And most recently, I was exploring that with my team, and we saw that gender minority individuals had more likely to experience an adverse childhood experience unrelated to them being transgender. And that was very much correlated with subjective cognitive decline later in life. We're also seeing sleep, that 7 hour kind of threshold. We're seeing more disordered sleep patterns among gender minority adults. And that has also been correlated with subjective cognitive decline. Sleep is another kind of optional module. So we're trying to leverage these data as best as we can to kind of understand and give us almost preliminary data to then further go in and collect information that is more specific to the gender minority population that could help us. So there's been some research, I'm not as familiar with the specifics, that have looked at just cognition in general as younger gender minority individuals starting to use gender affirming hormone therapy. And they're not seeing any adverse effects of the therapy, but also a lot of younger people are not going on hormones until they're closer to like a young adult age. It is, and I think it's an area where people are doing more and more research on this. Particularly, I think the long-term effects of these is something that is still under development.
This is very fascinating. I didn't know about the sleep aspect. And I wonder too, because we focus a lot of these risk factors, but I wonder those individuals who feel that they did have more support, what are some of the protective factors? What are some within the group? There may be some individuals who have less cognitive concerns, and I wonder what may be some of those factors that may be protecting them. I'm guessing like maybe like family support may be one of them, but I don't know. I wonder if that's also been discussed.
Yeah, I love your focus and attention on more resilience and how we could improve health and not just think about deficits. So I appreciate that. And you're right, affirming the individual from family, friends, colleagues, using their name, the right pronouns, has shown to significantly increase their health and reduce suicidality. Even thinking about children, twins, and being able to measure over time, over 3 to 5 years, is shown big improvement. The other protective factor is a sense of community and connection with community, which is challenging, especially coming out of COVID, where we all kind of lost that sense of connection. Gender minority people can already be disconnected and not know where their community is, given the stigma associated with that. But we do see that also is a protective factor. Having affirming providers, gender minority individuals may travel hours to have that affirming provider, but once they do have one, they engage in healthcare and they do the preventative services that could help us really identify concerns before when we can address them. But I think the unfortunate reality is, even though a lot of this anti-transgender legislation is targeting youth, it still negatively affects all members at all ages of the gender minority population, because it's sending that message that you're abnormal and you're not really welcome here, because it's not just about hormones. it's trying to eliminate and eradicate gender minority individuals from society.
Yes, of course. Do you find that social media helps with this sense of belonging or a community? Has there been any work towards using that as a platform to not only educate but also create that sense of belonging?
I haven't seen as much of that like in more aging studies, but definitely more youth and young adults using that. I know during COVID, there were some organizations that, they went to an online format to help with the social isolation, and that was really helpful. We're seeing, gender minority individuals as they're aging, they want to age in place. The long-term care facilities, they're having to almost kind of go back into the closet and hide who they are, and some individuals really can't do that, especially if they've require, because if they are on hormones, it is a lifetime commitment. If they've had
Right,
surgeries, they're depending on other individuals to help care for them, and that is not something that they could kind of hide the any type of scarring. So aging in place may not have family members from family of origin or children taking care of them. So other community members are stepping in. There's a couple of case studies that have come out highlighting the effects of being in these long-term care facilities when the staff is not affirming, and it's like reinforcing the sex assigned at birth to the individual. It's not that they are forgetting who they are. It's maybe they're confused in general, and then they're taking the environmental cues of what's going on.
interesting. I hadn't even thought about that. Great. Are there any other questions for Dr. Cicero? All right. Well, this was really amazing. Thank you so much for the work that you do. It is so important, and I hope it inspires other people to do similar work, but also to be more mindful about how we design our studies moving forward. Um, I hope you all have a great weekend, and thank you again so much for accepting our invitation and presenting your work.
Thank you so much. I really appreciate it. You all are doing fabulous work, and I'm grateful to be part of it.
Thank you. All right. Have a great day, everyone. Bye.